Hello, everyone. Welcome to our webinar where we will be reviewing a 2020 update on office-based anesthesia led by Dr. Fred Shapiro and Dr. Richard Ehrman. I am Rosalind Ritchie, Medical Director at the Center for Advanced Surgery at the University of Kentucky, and I am Chair of the Office-Based Anesthesia Committee for SAMBA. I will moderate this webinar. For those of you who are not SAMBA members, please consider joining the society as it offers many benefits to the members. Please visit our website at www.sambahq.org to see the benefits of membership. Now, for a quick housekeeping note before we get to today's presentation. In the upper right side of your computer screen, you will see a control panel. Please note that this webinar is listen-only mode. Submit your question in the chat box. You can type in a question or even comment and submit it at any time during the presentation. We will have time for questions and answers at the end of the presentation. Now let me introduce our great speakers today, Dr. Fred Shapiro and Dr. Richard Ehrman. Dr. Fred Shapiro is an associate professor of anesthesia at Harvard Medical School, Beth Israel Deaconess Medical Center Department of Anesthesia, Critical Care, and Pain Medicine in Boston, Mass. Dr. Shapiro serves on the SAMBA Education as well as the Office-Based Anesthesia Committees and is an advisor to the Residence Committee. It is important to note that Dr. Fred Shapiro is also the immediate past chair of the ASA Committee on Patient Safety and Education. Our second presenter today is Dr. Richard Ehrman. He is an associate professor of anesthesia at Harvard Medical School, Brigham and Women's Hospital, and the director of the Center for Perioperative Research. Dr. Ehrman also serves as the chair of the SAMBA Communications Committee, the ASA Abstract Subcommittee on Patient Safety and Practice Management. Now for our presentation, Dr. Shapiro, you may begin.
Thank you, Rosalind.
Welcome.
I have nothing to disclose. Just to let you know that Rich and I founded a nonprofit patient safety organization, the Institute for Safety in Office-Based Surgery, and the purpose was to promote patient safety and outcome research, design tools for advanced detection and prevention of adverse events, collaboration between all subspecialties, educate physicians and patients, ultimately generating an evidence-based standard of safer office care. The learning objectives for this evening's webinar are, first, to identify the most common safety-related issues encountered in the office-based surgical and anesthesia setting, understand the key safety considerations when setting up a safe office-based surgical practice, understand the safety issues regarding appropriate patient and procedure selection, and a little bit about practice management, facility accreditation, checklists, and emergency preparedness. Specifically, my section of the webinar will review the office-based anesthesia and surgery, some of the safety literature, talk about accreditation, challenges and updates in 2018 and 19, hot topics in practice management, and an update in state regulation. And below are two of our most recent publications where the talk comes from. Recently, all of these people have in common that they died undergoing an office-based anesthesia and surgical procedure. A teen of malignant hyperthermia, an 8-year-old in a dental's office, a 25-year-old having extraction of wisdom teeth, a 3-year-old, and everyone also knows about Joan Rivers. In 2011, this came from the USA Today, and it looks at 2 women who died after having liposuction. Unfortunately, their doctor was not board certified, took a weekend course in cosmetic surgery, and there was no law to stop him. Now, this was in 2011. This same occurrence happened in Florida in May of 2019. events continued to occur. Another article in USA Today, what the public read, was about these surgeries leading to tragic results. A comment from Bill Prentice from the Ambulatory Surgery Center Association, and he said that we shouldn't have a patchwork system. One state asks for one thing, others for other. What we need is consistency. So we did a little research on this. And in fact, if you look at this chart, we do have a patchwork. This is from the ASA. We currently have 33 states have legislation. The reporting of adverse events varies from state to state. And 17 states actually have no mandatory adverse event reporting. Therefore, outcome data is very challenging. So to sum it up, what are some of the safety issues that we see now from office-based anesthesia and surgery? Well, it's been called the Wild West because there's a lack of uniform regulation, an increased number and variety of cases, increased complexity of cases and patients, sedation by anesthesia and non-anesthesia personnel, and widely publicized fatalities, malpractice claims, similar to what we showed you. Hector Vila started the safety movement in office-based anesthesia in 2003 when he did a study published in Archives of Surgery to compare outcomes between offices and ambulatory surgery centers. And what they found is that there was a tenfold increase in adverse events and deaths in the office. Now later he commented, and years later, and he said that the numerator was due to both accredited and unaccredited offices, and the fact remained is each state had different risk factors in terms of the reporting of the data. When we look at the ASA closed claim project in 1996, the claims, there were only about 14 to 16 claims at that time. And at that time, death comprised 2/3 of the claims versus the ambulatory surgery setting, where temporary injury comprised 2/3 of the claim. 15 years later, when Ricky Twersky published this article and looked at the closed claims analysis, what they found was that death and permanent disabling injury was 27% and 17% in both the ambulatory surgery center and the office-based anesthesia setting. So what you can infer is that in the 15 years that the offices, the safety was being addressed, and they were playing on an equal level playing ground. In 2014, we got together to establish a benchmarking. It was to look at the literature regarding safety and outcomes in office-based anesthesia. And what we found at that time was that there was a lack of randomized controlled trials. But in our group, we had a consensus opinion that we could increase quality of care by engaging a proper procedure and patient selection, provider credentialing, facility accreditation, and incorporating patient safety checklists and professional society guidelines into practice. And these areas are going to guide the next part of the webinar. We created a checklist in 2011 based on the World Health Organization checklist. We worked with the tool Gawande, same format. And we are proud to say that our checklist for practitioners was featured in 2016 in the American Society of Healthcare Risk Management as a resource. We did a study in a plastic surgery center in 2012. We took the checklist to see whether we would to decrease the incidence of adverse outcomes and to educate practitioners and support staff. We looked at 219 cases, and we looked at baseline and post-operative adverse outcomes and post-checklist implementation chart review. And what we found is that prior to the checklist, you can see that there were missing documentation of 3 or more elements. For example, the EMS policy, the case-specific equipment, estimated blood loss, and the practitioner confirms verbally local anesthetic toxicity. These yellow check marks mean that this was not documented on the chart. And you can see patient medically optimized and the site inside. After the implementation of the checklist, this improved. In addition, we found that 15% of the cases had adverse events Pain and bleeding and bruising were the most common. And post-checklist implementation, 90 to 100% increase in documentation of these several key indicators and practices. We switched gears in 2013 and created a checklist for patients. That is to engage, empower, educate patients so they can ensure their own safety. In 2016, this checklist was added to the Harvard Pilgrim Healthcare website and the newsletter that was sent to over 400,000 subscribers. Recently, we published the current opinions article looking at the literature from 2016 to 2019. Dr. Ehrman is going to address some of the safety literature, but basically in this article, it was published in September, we looked at the ASA SAMBA statements and guidelines, cognitive aid resources, the safety literature in cosmetic, dermatology, dental, ophthalmology, ORL procedures, and we found a low number of complication rates due to proper patient selection. Again, to review, we reiterated that 17 states lack regulation, adverse event reporting, and it limits outcome analysis in order to get adequate benchmarking. In the dental anesthesia literature, Allison Spira looked at the ASA closed claims data for dental cases over a 4-year period from 2010 to 2014. She looked at 7,000 cases, 3% adverse events. Prior to discharge, the main event was laryngospasm, and post-discharge, the main event was nausea. So this article basically supported the safety of office-based anesthesia performed by dentist anesthesiologists in the treatment of pediatric dental patients. The reason why I included this is because pediatric sedation in dental office, as you can see by the unfortunate events that I showed the pictures, and also pediatric the adverse events that we've seen, has really spurred on the legislation and guidelines and statements that we'll share with you later in the webinar. In terms of the plastic surgery literature, CosmetiSure data came out in 2017, and this CosmetiSure data was a special malpractice insurance from board-certified accredited physicians. Specifically, they looked at liposuction procedures, 31,000, 11,500 of which were solitary procedures. The major complications were hematoma, pulmonary complications, infection, and venous thromboembolism. And it was found that independent risk factors were combined procedures performed in hospitals, age, and BMI. And you can see from this diagram, it just reiterates the body mass index, the additional procedures, and the place of surgery. It's interesting to note that of the places of surgery, the office was the least amount of complication. In terms of interventional vascular procedures, this study came out in Vascular Surgery Journal. They looked at 5,000 consecutive procedures between 2006 and 2013, looking at diagnostic arteriograms, arterial interventions, venous interventions, dialysis access interventions, and venous catheter management. And the conclusion was that endovascular procedures can be safely performed in an office-based facility with excellent outcomes. We use mobile anesthesiology. We're working with them as an example, to see where the horizon is with the types of cases that are being performed in the office. Centurion Anesthesia is based in New York. They have greater than 60 active anesthesiologists, 85% are board certified, greater than 40 active CRNAs. They act in 7 states, and there's New York, New Jersey, Connecticut, Massachusetts, Florida, California, Illinois, and they recently opened another office in Georgia. The typical day is 20 to 35 locations. But most importantly, if you look at the right side of the diagram, in 2014, when Rich Ehrman and I looked at the closed claims data, the main procedures were orthopedics, pain management, GI, ENT, podiatry, gynecologic procedures, dental procedures, and plastic surgery. But the cases that are performed by groups such as Centurion Anesthesia, the most common procedures are in urology, vascular surgery, embolization, angioplasty, and ophthalmology. So the landscape between the cases has changed in the past 5 years, indicating there is an increased complexity of patients, procedures, and ongoing in the office-based setting. In 2009, I was privileged to work with Beverly Phillip and Ricky Twersky, and we wrote the ASA manual on consideration for setting up and maintaining a safe office-based anesthesia environment. And the 4 areas that we worked on were administration of facility, clinical care, resource materials, and the appendices. And you see the guidelines. Briefly about accreditation, Rich Ehrman and Beverly Phillip wrote a wonderful anesthesiology clinics article in 2014. And in summary, accreditation, why do people accredit their offices? For external validation of safe practices, benchmarking performance against other accredited facilities, and it also demonstrates to patients and payers the facility's commitment to continuous quality improvement. Each accreditation agency, the Joint Commission, the AAAHC, and Quad A, each one of them every year presents their top 10 standard deficiencies when they do surveys. And one of the things that we found is that across the board in 2016, 17, and 18, one of the standards that was deficient was emergency preparedness. This prompted us in 2007 to prepare the ISOBIS office-based emergency manual. We compiled this from the Stanford, the MGH manual, Malignant Hyperthermia Association, ACLS, PALS, and we surveyed a consensus of experts and found 26 areas that were the most common areas for the office, in addition to those unique areas that would pertain to the office-based anesthesia surgical setting. In addition, if you note, we had one section for adult life support and pediatric life support. In the incidents, like we described, the many mishaps that are happening in the dental office. In the pediatric area, we give the dilution and drug dosing regimen. But this is in similar format, the Ariadne format, as the Stanford and MGH manuals. And this is now accepted on the emergency manuals website with these other cognitive aids. In 2019, the Joint Commission revised the survey eligibility criteria for office-based surgery. In summary, the practice has to have a license or registration to conduct this scope of service. The tests and treatments have to be prescribed or ordered by a licensed independent practitioner in accordance with state and federal requirements. The practice must be surgeon-owned or operated. The practice provides invasive procedures to patients under local anesthesia, minimal sedation, moderate sedation, or general anesthesia. In addition, the Joint Commission in 2019 released the Office-Based Surgery National Patient Safety Goals. And basically, there were 4 areas that were highlighted. Number 1, to improve the accuracy of patient identification. 2, to improve the safety of using medications. 3, to reduce the risk of healthcare-associated infections. And 4, a universal protocol to prevent wrong site, wrong procedure, wrong patient. In 2019, January, the Joint Commission also revised pain management and assessment standards. And this is applies to accredited ambulatory surgery centers, critical care hospitals, and office-based surgery practices. Due to the fact that there's an increased landscape of procedures in the office-based setting, there were also changes to requirements for fluoroscopy services and computed tomography units, and establishing a radiation safety officer. In 2017, the New York Department of Health required reporting of adverse events through electronic reporting tool. and this was mandatory. A little bit about the ASA legislative reports in 2018 and 19. The ASA on the website has statements and guidelines revised on ambulatory and office-based anesthesia, distinguishing monitored anesthesia care versus moderate sedation, the statement and qualifications of anesthesia providers in the office-based anesthesia setting, the ASA statement on sedation and anesthesia administration in dental-based, office-based settings, and practice guidelines for moderate procedural sedation analgesia in 2018. Specifically, what was unique about the practice guidelines for moderate procedural sedation published in Anesthesiology in 2018, that this was a report that was endorsed by not only by the ASA, but the American Association of Oromaxillofacial Surgeons, Radiologists, Dentists, Dental Anesthesiologists, and the Society of Interventional Radiology. Highlights of these new moderate sedation recommendations were continual monitoring of ventilatory function with capnography that would supplement standard monitoring by observation and pulse oximetry, and the presence of an individual in the procedure room with the knowledge and skills to recognize and treat airway complications. The most recent guidelines, it was a joint statement approved by the American Academy of Pediatrics, American Academy of Pediatric Dentists, and the ASA in June 2019, regarding pediatric sedation before, during, and after diagnostic and therapeutic procedures. This applies to both facilities or hospitals. The key issues are the requirement of 2 persons in the room with proper training and credentials while the patient is undergoing dental treatment under deep sedation or general anesthesia. What the definition of a qualified anesthesia personnel in this setting would be a physician anesthesiologist, a CRNA, a dentist anesthesiologist, or a second oral surgeon. But the fact is, one person's sole responsibility was to constantly observe the patient's vital sign and have to be skilled in handling emergencies. Another issue is that both the dentist and the independent observer in the room have to be PALS certified. A common question that's always asked in the office-based setting is regarding succinyl choline, malignant hyperthermia, and dantrolene. The question comes up that if the office does not use succinyl choline or an inhalation agent, does it need to stock dantrolene or Ryanodac? The Society for Ambulatory Anesthesia prepared a statement in a special article in May 2017 on emergency airway rescue in Class B ambulatory facilities. Procedures in Class B facilities performed exclusively with oral or IV sedative and analgesics. These traditionally do not stock dantrolene because there's no known triggers of malignant hyperthermia, i.e. inhaled anesthetics and succinyl choline. The article argues that in the absence of succinyl choline, the morbidity and mortality from laryngospasm can be significant, higher than the unlikely scenario of succinyl choline triggered malignant hyperthermia. So the take-home message is from the statement, from the SAMBA statement in 2017, in the absence of succinyl choline, the morbidity and mortality from laryngospasm can be significant and actually higher than succinyl choline triggered malignant hyperthermia. An interesting article in talking about legislation with office-based surgical procedures comes from the American Journal of Public Health in 2018. And this was highlighting the comparison between abortion clinics and other office-based settings. This is questioned the constitutionality of targeted regulation of abortion providers versus current office-based surgery laws. This was in Texas. It's called the Whole Women's Health versus Hellerstadt. The abortion law required that abortion clinics had to be licensed ambulatory surgery center facilities, and the physician had to have hospital admitting privileges. So the conclusion from this was that the states regulate abortion providing facilities more stringently than facilities providing office intervention. Well, for the purpose of our webinar, if we look at the office-based settings, you can look at the chart from this article. If you look at some of the highlights with the requirements in terms of facility licensing and accreditation, of the 25 states that were reviewed as of 2016, 44% had neither licensing or accreditation was specified. In terms of specialized rooms, you can see none of these rooms were specified. Physical plant specifications, none of these features were specified. In terms of physician qualifications, if you look at the office-based setting, no physician qualifications were specified, 52%, and in terms of nursing, 28%. In addition, if you look at required arrangements to facilitate patient transfers from the office, in terms of the admitting privileges and transfer agreements, there was 0%, and no arrangements for patient transfers were 20%. And in fact, the penalties for this were there was lack of penalties for office-based settings in 72%. A unique area that the Joint Commission provides, if one wants to look up their state regulation, is if you go on the website and you can see the link below. You can plug in your state and you press office-based surgery and it will list all the office-based guidelines. I'm proud to say that the Mass Medical Society, we work together to update the office-based surgery guidelines this year. They'll be coming out in 2020. And last, before I turn it over to Dr. Ehrman, so what can we say about ambulatory surgery and their liability risk? As you can see from the closed claims data in 1996 to 2013, office-based surgery has improved. Our literature review in 2019 also shows that it's improved. But also the caveat is that the landscape of cases is increasing complexity as well as the patients and procedures. So what can we say? I think it's best to be summed up by Julia Metzner and Christopher Kent from Current Opinions, 2012. Due to the changing landscape of ambulatory practice permits care for sicker patients who require more complex surgeries, anesthesiologists continue to be confronted with new areas of liability. And now I thank you, and I turn the webinar over to my dear friend and colleague, Dr. Rich Ehrman.
Oh, thank you, Fred. We'll continue our discussion on safety in the office-based setting. I have no relevant financial disclosures. And the goals of this presentation are to recognize the importance of adult patient selection in the office. We'll provide an evidence-based review of the literature on patient outcomes and develop patient selection criteria for your office-based practice. I have a list here of patient conditions. And the question is, how much evidence do we have for patients who are increasingly getting sicker and presenting to the busy office-based practices with these medical conditions? Which patients are okay to have surgery in the office-based setting or any ambulatory setting? And how much evidence do we really have about patients with significant OSA, COPD, morbid obesity, coronary artery disease, renal or liver disease? And the answer is, there's limited evidence for patient selection in the office-based setting. And often we have to extrapolate the evidence based on what we know from outcome studies in other ambulatory non-office-based settings. This is a busy slide, but it just gives you a sense of the fact that a lot of the guidelines and patient selection criteria are based on consensus by experts rather than real evidence. And this is one example where sometimes in the right lower corner, when they ask anesthesia practitioners, what types of patients are not appropriate for the ambulatory setting, not specifically office-based setting. And, some of these are pretty obvious, patients that have significant comorbidities, But it's really this gray zone where, it really depends where the patient is appropriate or not appropriate. Still remains a question. So patient selection really is contingent upon multiple factors. It's not just the patient's comorbidities, but it's the procedure that's being planned. It's the skill of the surgeon, conditions of the facility, and capabilities of the facility, skills of the anesthesiologist, as well as anesthetic techniques that are required. We published this paper some time ago simply to demonstrate the sort of type of demographics, the types of patients who undergo office-based surgery using NACOR, Nationwide Anesthesia, National Anesthesia Clinical Outcomes Registry. And clearly, over the years, we see that patients are getting older. Patients in their 70s and 80s, the number of patients is growing in the office-based practice. And also, patients who are ASA 3 and 4, the number is growing. And in 2014, 32% of patients were ASA class 3, and almost 1% were ASA class 4. As Dr. Shapiro mentioned earlier, what can we learn from office-based closed claims analysis? And I highlighted a couple of things that basically say that, most closed claims involve respiratory and equipment-related events, and most involve patients who are middle-aged, generally healthy individuals. And so most common adverse event leading to injury was inadequate ventilation or oxygenation. So, looking at this limited closed claims analysis, it's difficult to conclude anything specific about the types of patients or comorbidities that are appropriate or not appropriate for the office-based setting. This is another paper that came out in plastic surgery a couple of years ago, and this was looking at patient outcomes in aesthetic procedures, including office-based procedures as well as ASCs. And again, the question is, are there specific patient-related risk factors that lead to higher complications that can help us with patient selection? And if you look at relative risk ratios, that's the table on the right, certainly things like age, BMI, gender, smoking, and diabetes come up as risk factors for increased complications. This is a paper that was actually looked at ambulatory surgery, not necessarily office-based surgery. Again, looking for specific patient conditions that predispose patients for high risk for complications, morbidity and mortality. Again, not limited to office-based setting, but the author specifically identified COPD, history of stroke, or TIA, BMI. And we'll get into details exactly what these BMI cutoffs really, what data we have about BMI cutoffs. Prior, cardiac surgery, prolonged surgical time, which appears again and again as a risk factor for complications in the ambulatory setting, and systemic hypertension. And if you look further, this is a Canadian study. It did not look at office-based practices, but it looked at ambulatory practices at 3 Canadian hospitals. And again, risk factors for unanticipated admission that were patient-related risk factors or procedure-related risk factors for high ASA class at 5 to 7 times higher, whether it's the ASA 3 or 4, advanced age, and you can see in this and other papers showing that patients aged greater than 80 clearly have a higher risk of unanticipated admission and complications. Again, length of surgery and the BMI specifically in the 30 to 35 range. But this paper, interestingly, did not identify any specific comorbid conditions associated with increased risk of unanticipated admission. So the question is, based on the data that we do have, whether it's ambulatory or office-based data, can we come up with specific objective criteria to help us with patient selection and create triage tools to safely take care of these patients? Age and ASA class always come up as a selection criteria for the office-based practice. Again, we're looking, turning to ambulatory literature, not necessarily office-based literature. And not only is there variability in how ASA classes is assigned by providers, but many would argue that ASA class by itself may be a useful criterion, but you also have to look at the type of procedure as well as other factors that will help you decide whether an ASA3 or ASA4 patient. For example, if an ASA4 patient is undergoing simple eye surgery with minimal sedation, it's not the same as an ASA3 patient undergoing a complex, long procedure under general anesthesia. Age, again, comes up again, as there are definitely complications increasing with age. But, especially for the office-based practice, so any ambulatory practice, it's important to consider not just age, but also age-associated comorbidities or other associated factors such as medical conditions, social situation, and cognitive status, which can all impact postoperative recovery, intraoperative course, postoperative recovery, and post-discharge well-being. This is another paper, again, looking for selection criteria that is age-based or procedure-based. This was published over 15 years ago, looking at unanticipated admission and mortality after outpatient surgery in elderly patients. And clearly, a lot of the patients that we're taking care of in the office are elderly patients. And again, there's an increase with age, but also the authors look at specific procedures, and you can see that some of the procedures, like AV graft placement, for example, had a significantly higher odds ratio in terms of unanticipated admission. And certainly these procedures are increasingly being done in the office-based setting, as well as procedures like DNC and other procedures, carpal tunnel. So this is definitely helpful. This is another slide that was comes from a plastic surgery literature. And again, the question here is, patients looked at, the authors looked at many patients undergoing abdominoplasty. Patients had complications. However, interestingly, only one patient suffered a PE. And it turns out that the patient was taking oral contraceptive pills. So really not that much that we can conclude from this study, looking at over 2,000 patients, what are risk factors in this relatively healthy population that can help us decide on which patients are appropriate or not appropriate for office-based surgery. This is another paper, again, comes from plastic surgery, looking at abdominoplasty complication rates. And it turns out, you look at the table on the right lower hand corner, where it says risk factors for complications, and sounds like age, smoking, BMI, gender, diabetes, type of surgical facility, and that combined procedures definitely increase complication rates. Unfortunately, the good news, there are several validated tools that we can use to predict patient risk. Patients undergoing surgery. There's pericardial myocardial infarction, cardiac arrest risk calculators, ASC, NISQIC surgical risk calculators, pulmonary risk calculators. Unfortunately, a lot of them were not designed for ambulatory or office-based settings, and therefore, I would argue, not very useful to help you estimate risk and properly select patients, especially for the office-based surgery. And so we really have to look at other studies or maybe indirect evidence to make these decisions. This is another paper from plastic surgery. This looked at AAASF, internet-based quality assurance and peer-reviewed database. And these were actually outcomes. They look at the frequency of different outcomes, and no surprise that pulmonary embolism and cardiovascular complications were by far the most common complications. And the question is, patients who do suffer these complications, were there any pre-existing conditions or any procedure or facility-associated factors that led to these complications? But there were no, in this study, pretty large study, clearly, no specific patient-related risk factors were identified, and there were some deaths reported. And again, PE, most common cause of death. And really not much we can ascertain from this study in terms of any specific contributing factors. Obesity clearly is an epidemic nationwide, and we all know that they're associated with the conditions that I listed on this slide, such as sleep apnea, diabetes, technical difficulties, airway management, pulmonary hypertension, and cardiovascular disease. And these patients are coming to the office-based setting, and they're having simple as well as more complex surgeries. And so the question is whether it's, what can we learn from the ambulatory literature, not necessarily office-based literature, in terms of BMI cutoffs and who's appropriate, who's not appropriate. And this is a paper that was published in the Anesthesia Analgesia under SAMBA. It's a systematic review, but basically the authors determined that patients over BMI of 50 may be high risk for perioperative complications. 40 and 50 BMI range remain sort of a gray zone, and you really have to very carefully look at patient comorbidities. As I mentioned previously, to help you decide whether there'll be an appropriate patient for office-based or any ambulatory setting, and they may not be, depending on their comorbidities. This is a paper that we published recently, again, trying to understand what are the BMI, where do we see increased risk of unanticipated admission as a function of increasing BMI. And consistent with other literature, we found that when you increase BMI, when BMI is above 50, you start seeing increased risk of unanticipated admission. This is a very useful guideline from SAMBA, looking at patients with obstructive sleep apnea undergoing ambulatory surgery. And the question is who's appropriate, who's not appropriate for the ambulatory setting. And again, the emphasis is on examining comorbid conditions. It's not just one factor, but looking at are they adequately optimized, which can help you determine whether the patient should be done in the ambulatory setting and or office-based setting. This is another SAMBA statement that was published this year in Anesthesia Analgesia, in which I was involved. And the question was whether patients, again, talking about patient selection, if patient is MH susceptible, malignant hyperthermia susceptible patient, adult patient, is it okay to operate on these patients in the ambulatory surgery center? Now, not office-based setting. And our conclusion was that there's no evidence to recommend an extended stay in the ambulatory setting, and patient may be discharged when the usual discharge criteria for outpatient surgery are met. Finally, there's another guideline, and there's a diabetes just like obesity is an epidemic in the United States, and often patients may be denied surgery in the ambulatory office-based setting if they have significant diabetes, type 1 or type 2 diabetes. And this guideline, which is currently being updated, looked at the appropriateness of operating on diabetic patients in the ambulatory setting. And the guideline basically said that they do not recommend normalizing someone who's chronically elevated, but they did state a goal of optimal sugar level being under 180. Finally, hypertension. Lots of patients have hypertension, systemic hypertension. There's a guideline that recently came out that doesn't specifically look at ambulatory patients, but it specifically addresses elective procedures, and certainly, in my mind, applicable to the ambulatory settings. And the question was, what do we know about this preoperative hypertension, and how do we manage these patients, and ultimately who's appropriate, who's not appropriate, and when do we start seeing increased complication rates as a function of elevated systolic and diastolic blood pressure. And the conclusion was elective surgery should not be canceled based solely upon preoperative blood pressures, but you can use preoperative blood pressure to define targets for perioperative management. And ultimately, they said there's insufficient evidence to support lowering arterial blood pressure, as well as insufficient evidence that any one measure of arterial pressure, systolic, diastolic, or mean, is better than any other for risk prediction of adverse perioperative events. So please take a look at this paper. And finally, if you're looking at all the data that I just presented about patient selection, some important points to highlight is communication, effective communication between the anesthesia providers, the surgeon, and the patient, of course, setting exclusion criteria, which depend on your office, your practice type, and the resources that you have to deal with potential complications. Developing red flags about patients and their comorbidities. The other emphasis should be on getting as much information about the patient as you can, especially if many of them do not go to the preoperative clinic or undergo any sort of formal preoperative anesthesia assessment. And having them fill out anesthesia questionnaire about their medical conditions is very important, or conducting telephone interviews or any other way to obtain as much information as possible about these patients to make good decisions, evidence-based decisions about appropriateness of surgery in the office-based setting. Using existing recommendations from societies as well as papers that are out there, that just like the ones that we summarized, and education and benchmarking is important for your office-based facility. So thank you very much. And I turn back to Fred and Rosalind.
Thank you, Fred and Richard, for such an informative presentation. So we now have time for questions. And remember, in the upper right side of your computer screen, you will see a control panel. You can type in a question or even a comment and submit it during the presentation and during the question section. So I'll get started with some of the questions that we have. So you noted, Dr. Shapiro, in your presentation that the lack of succinylcholine to treat a laryngeal spasm has a higher risk of mortality and morbidity than a succinylcholine-induced MH crisis. I find this hard to believe. Can you explain a little bit more where this statement comes from and what the evidence is behind it?
In the paper that the SAMBA, okay, in the SAMBA statement, okay, there was a original article in 2013 by Dexter, and it was published in Anesthesia and Analgesia. We're looking at the same issue, and the actual percentage of malignant hyperthermia that they looked at, malignant hyperthermia could be induced by succinylcholine alone versus succinylcholine and combined with inhalation agents. And the data was really inconclusive whether succinylcholine, whether these offices or ambulatory surgery centers should stock dantrolene or Ryanodex at the time, because the data was inconclusive whether they could prove that succinylcholine alone versus inhalation agents could induce malignant hyperthermia. That being said, at that time, it was very, very low, but the data was inconclusive. So the statement at that time was, in the absence of evidence, that the offices and ambulatory surgery centers should stock their facilities with adequate supplies of dantrolene or Ryanodex. And until the literature supported one way or another, that was the issue. Then in 2017, the issue came up because there's been a lot of morbidity and mortality with pediatric, as you see with the pediatric dental offices, with the mishaps such as similar to what happened with Joan Rivers, things like that. So the question came up about the Class B facilities to a consensus opinion of SAMBA experts, which led to the statement from SAMBA in 2017 regarding that the issue of, by not having succinylcholine and the risk of laryngospasm to prevent an emergency airway issue was higher than the issue of malignant hyperthermia with succinylcholine, and that's where that came from.
Okay, thank you. So you mentioned about the pediatric sedation in dental offices, and you mentioned that 2 personnel must be involved in the care of the patient, but looking at that slide, I can't go back to it. One of our audience wants to ask the question, is this only for deep sedation and general anesthesia, What about moderate sedation or light sedation in the pediatric office?
I think that it was recommended for moderate deep sedation and general anesthesia, but specifically addressing deep sedation and general anesthesia. I think from what the statement says, I think that's the major concern.
Okay. All right. Let's see here.
Do you
have? Go ahead. Mm-hmm.
No, but I think
someone's typing, so go ahead.
I think it's the level of consciousness of the patient.
Mm-hmm. Okay. All right. Do we have any more questions?
There is one that has come in from a participant, and the question is the risk with higher BMI related to airway problems?
Is the risk of higher BMI, is the risk of, can you repeat that? I'm sorry.
Sure. Is the risk with higher BMI related to airway problems?
Well, the answer is yes. In the general literature, there's really a lack of evidence in the office-based literature, even looking at closed claims analyses specifically, to show any definitive risk. But it's certainly been demonstrated in a variety of other settings and literature to support association of increasing BMI with respiratory events. And that's very clear, including some of the existing ambulatory literature. But clearly, increasing BMI is associated with many other complications, airway and respiratory events being one of them. Again, when we look at this literature, a lot of it comes from non-office-based ambulatory settings. A lot of it comes from other settings. And so, using the evidence that we do have, we would have to conclude that, there's clearly an association between BMI and increased respiratory events, as well as, intubation-related events.
Okay, we have another question. Dr. Shapiro, you mentioned that office-based procedures are 10 times greater in the hospital compared to the office. Is that correct?
No. I repeat the question again. I just want to hear.
Okay. So you mentioned that the morbidity and mortality of procedures done in the office are actually 10 times less than in an ambulatory surgery center. But 20 years ago, it was 10 times more. Or what do you mean by that? So what happened between the 20 years?
Okay, just to clarify what happened. In 2003, when Hector Vila published his original paper looking at comparing ambulatory surgery centers and offices in terms of adverse outcomes, they found that there was a 10 times increase of adverse outcomes and death in the office versus the ambulatory surgery center. Now, what Hector Vila, when he commented on the Gupta article that was published recently, what they found was they looked at 183,000 office-based plastic procedures, and they found that the offices of looking at offices versus ambulatory surgery centers versus hospitals, Gupta found that offices with the least number of area where there were complications in the procedures. So when Hector Vila was asked to comment on this article, this is 15 years after he published the original article, what he said was that proper patient selection and facility accreditation and risk stratification by the preoperative evaluation could improve patient safety. And that's what that's the literature there. I don't think that we know the number of the percentage now, but that's the literature. It was 1.6% compare in the Gupta article in 2018. That's from the Cosmetasure data evaluating plastic surgery cases from 2006 to 2013. And Cosmetasure data is from board certified accredited offices. Just a caveat, that was the article that Hector Vila commented on recently. Just a caveat, when Hector Vila looked at his original article from 2003, the numerator was accredited and unaccredited offices versus the denominator was only accredited offices. When Hector Vila commented on this article after the Gupta article, he said that most of the adverse incidents came from the unaccredited offices, but that wasn't clear at the time in 2003. But the take-home message here is that Vila, in Archives of Surgery in 2003, initiated the conversation about patient safety in the office-based surgical setting, because at that time there were many adverse events happening in Florida, and that's what prompted him to look at this issue. So whether the data was incorrect at that time, it prompted a movement that led us to this webinar in 2020.
Thank you. Thank you, Fred and Richard, for such an informative presentation again. Thank you all for participating in this webinar, and do not forget that this month we are working in collaboration with ASA to offer CME credit for attendance at this webinar. Once the webinar ends, you will be prompted to take a post-test, and your CME certificate will then be available within ASA's transcript page. Webinar participants will also receive an email from SAMBA that includes a link to an evaluation. Please take a minute to provide your feedback. The recording of today's webinar, along with any handouts discussed, will be posted on SAMBA's website in the near future. We hope you will join us for upcoming webinars. We will send out a notification to members once registration is available for our next November session. Thank you again, and have a good night.